Welcome back to another episode of the Irish Hematology Oncology podcast, where we aim for this podcast to be like grabbing a coffee with a trusted colleague to discuss the latest in cancer care, break down complex topics, and share practical experiences. I'm your host, Eoin Tabb. All right, grab another CPD break and settle in, because today we're ditching the old school carpet bombing approach of chemotherapy and talking precision strikes. Targeted therapies and immunotherapy are the future of cancer treatment. It's like comparing a blunderbuss to a sniper rifle. Let's dissect how they pinpoint cancer's unique weaknesses and revolutionize the fight. If you thought the first episode was interesting, just wait for this one. So targeted therapies, they're the sharpshooters of cancer treatment. If cytotoxic chemotherapy is like a broad spectrum attack, targeted therapies are akin to precision guided strikes. These drugs home in on the specific vulnerabilities within cancer cells, interfering with the pathways that drive their growth, survival, and ability to spread. This more tailored approach often translates to treatments with greater effectiveness and potentially fewer side effects compared to traditional chemotherapy. Let's dissect the key categories of targeted therapies. We're going to give the same structure as last week, the scientific stuff, examples in practice, and then a fun analogy to try and help you remember. So the first category we're going to go to is tyrosine kinase inhibitors, or TKIs. They're blocking the communication networks. So their mechanism of action. Tyrosine kinases are enzymes that act like cellular signal amplifiers. When specific molecules bind to them, they switch on pathways promoting cell growth, division, and survival. Unfortunately, cancer often hijacks these pathways. Mutations in genes that code for tyrosine kinases can make them constantly active, like a switch stuck in the on position, fueling uncontrolled cancer growth. TKIs work by fitting into the active site of these faulty tyrosine kinases, blocking their ability to transmit signals. So I'll give you a few examples. Imatinib. So this was a revolutionary drug that transformed chronic myeloid leukemia, or CML. It targets the abral BCR-ABL tyrosine kinase, a defining feature of CML. Other ones are Erlotinib and Gefitinib. They're used in certain lung cancers with mutations in the epidermal growth factor receptor, EGFR, tyrosine kinase. And many more TKIs exist as well. I'm not going to dive into each of them. But each of them, I suppose, is important to remember, are designed for the specific tyrosine kinase mutations found in various cancers. So now a fun analogy. In cancer cells as a group of relaying walkie-talkies that rely on this channel to communicate their growth plans. TKIs act like jammers. They scramble the message and prevent the coordination. So once you have one of the walkie-talkies shut off, the whole rest will shut off. Okay, our second category then is monoclonal antibodies. These are harnessing the immune system and intercepting signals. So the mechanism of action of these guys, our immune system naturally produces antibodies, proteins that hunt down specific foreign invaders. Monoclonal antibodies are lab-made versions designed to latch onto antigens frequently found on cancer cells or within the tumor environment. They work in several different ways, and it's important, I suppose, to know that this is more of a target and that there's several different mechanisms of action within each of the monoclonal antibodies. I'm going to keep it vague today, but just to get you a broad understanding of it. So what they can do, that they can tag for demolition. So some monoclonal antibodies act like flags, marking cancer cells for destruction by the immune system. They can also block growth signals, so others bind to receptors on cancer cells, preventing growth-promoting molecules from attaching and turning on pro-cancer pathways. And they can also deliver a payload. Certain monoclonal antibodies act as delivery trucks, carrying toxic substances directly to cancer cells for targeted destruction. So a few examples. Rituximab. This targets CD20, which is a protein present on many lymphoma cells and triggers immune system attack, cell lysis, and complement-mediated cytotoxicity. Trastuzumab, that works in HER2-positive breast cancers by blocking the HER2 receptor, which is overactive in this cancer subtype. And cetuximab, this blocks EGFR signaling used in certain colorectal and head and neck cancers as well. So again, onto our analogy. So think of monoclonal antibodies as having multiple functions. They can call in a special forces team, they can barricade the entrance that supplies arrive through, or they can even plant explosives directly inside a cancer cell's hideout. Now we'll go on to hormonal therapies. They're starving hormone-dependent. So these guys, their mechanism of action is hormones like estrogen and testosterone can act like fuel for some cancers, most notably breast, prostate cancer. Hormonal therapies disrupt this supply line by 1. Blocking hormone production. Drugs can prevent the body from creating these hormones in the first place altogether. Or secondly, they can interfere with hormone receptors. So other hormonal therapies bind to the receptors on cancer cells, preventing hormones from delivering their growth-promoting messages. So a couple of examples of these, tamoxifen, that blocks estrogen receptors in breast cancer cells. Aromatase inhibitors, so examples of those are letrozole and anastrozole. These reduce estrogen production. They're used mainly in postmenopausal women with breast cancer. And then you have androgen blockers. So the examples of those are abiraterone. So that's used in prostate cancer to lower testosterone levels or prevent its action. So the analogy here, if certain cancers thrive on a high octane fuel source, hormonal therapies can either shut down the gas station or clog the fuel line into the cancer cell and prevent that fuel source from ever reaching it and from driving that cancer cell growth. The next category we're going to look at, and I touched a bit upon it in the monoclonal antibody section, are antibody drug conjugates, or ADCs. These are guided missile delivery. So the mechanism of action. So imagine a Trojan horse delivered directly to a cancer cell. ADCs combine the targeting ability of a monoclonal antibody with a potent cell-killing drug, like a tiny but very, 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 very powerful bomb. The antibody binds to specific markers on the cancer cell, and that transports the drug, the cytotoxic drug payload, directly inside where it unleashes its destructive power. So examples of this are trastuzumab emtansine, or TDM1. That targets HER2 in breast cancer. And brentuximab vedotin, so that targets CD30 in certain lymphomas. So let's just break down the two of those drugs there. So trastuzumab emtansine. Trastuzumab is your monoclonal body carrier, and emtansine is your cytotoxic payload drug. Again, with brentuximab is your monoclonal antibody, and vedotin then is your cytotoxic payload drug. So again, fun analogy. Think of the ADC as a smart delivery package. It has a specific address, which is the antibody part, that ensures it only arrives at cancer cells. And inside is a potent surprise, which is the drug payload, and that's meant to disrupt the cell's operations. Okay, so we go on to the next category, and I probably should have spoken about this next category in last week's episode, as it's not a targeted therapy per se, but rather a means of utilizing the cell's ability to tidy itself up as a target to prevent rapid cell proliferation. So what I am talking about is proteasome inhibitors. They clog up the cellular recycling system. So the mechanism of action is right. Proteasomes are like tiny cellular rubbish trucks. They're responsible for breaking down unneeded or damaged proteins. Cancer cells often become highly dependent on this protein recycling system to maintain their rapid growth. Proteasome inhibitors jam this disposal mechanism, so it's the rubbish truck breaking down that rubbish. It blocks that up and prevents that. So that leads to a buildup of these faulty proteins inside cancer cells, and that ultimately triggers cell death. So the examples of this are bortezomib, carfilzomib, ixazomib. They're used primarily in multiple myeloma and some lymphomas. So again, an analogy, imagine a cell as O'Connell Street in Dublin. If the street sweeper breaks down, the street soon becomes overrun with rubbish, making it impossible to function and walk safely down the street. Similarly, jamming the proteasome creates chaos within the cancer cell and again causes it unable to function and causes cancer cell death. So a quick note on targeted therapies. While still possessing side effects, these treatments are frequently better tolerated than traditional chemotherapy. However, a patient needs to express a target for a drug to be able to attach to it. That's why testing for biomarkers is important to know that these drugs will work on that specific patient. Ongoing research explores further targets and even more precise ways to exploit cancer-specific weaknesses. So now we're going to move on to the topic of immunotherapy, and there's several subcategories of this, and we'll go through that. So immunotherapy is unleashing your inner defender. Your immune system is a complex network of cells and molecules designed to protect you from threats, both external bacteria and viruses and internal like abnormal cells. Cancer, however, has very, very devious ways to evade immune detection and even suppress the body's defenses. Immunotherapy aims to tip the scales back in the favor of your immune system, equipping it with the tools and strategies to better see and destroy cancer cells. So here's a breakdown of some key types of immunotherapy. So you have immune checkpoint inhibitors. They take the brakes off the immune system. So think of your immune system as an army with built-in safety protocols. Checkpoint proteins such as CTLA4, PD1, and PDL1 act as stop signals to prevent the immune system from going overboard and attacking healthy cells. Unfortunately, cancer cells sometimes take advantage of these safety mechanisms, displaying disguised molecules that interact with checkpoint proteins to evade destruction. Immune checkpoint inhibitors block these interactions. They essentially take the brakes off the immune system and allow it to unleash its full force against cancer. So the examples of this are Ipilimumab, that targets CTLA4, Nivolumab and Pembrolizumab, they target PD1, and Atezolizumab that targets PDL1. So imagine cancer cells are wearing cloaking devices that trick your immune system into thinking they're harmless. Checkpoint inhibitors tear off that cloak, revealing the cancer cells to an energized immune system that's ready for battle. The other subcategory are adoptive cell ACT, supercharging immune soldiers. So ACT involves collecting a patient's own immune cells. These are usually T cells, modifying them in the lab to specifically target that patient's cancer, then multiplying these cells and infusing them back into the patient. The most common type of ACT, and only one available in Ireland, is CAR T cell therapy. So CAR T cell therapy, in this revolutionary, a patient's T cells are genetically geared to express chimeric antigen receptors, or the CAR. These CARs allow the T cells to recognize a specific protein on the surface of cancer cells. The souped up T cells are like a personalized fighting force designed to find and destroy the unique enemy that is the patient's cancer. So we'll do our little analogy here. So ACT is like taking a small group of your immune cells, fitting them with a sophisticated enemy detection system, training them into elite fighters, and then sending them back on a mission to seek and destroy the cancer cells. Now we'll go on to a bispecific T cell engagers, or BiTEs. They bridge the gap for the immune attack. So BiTEs are engineered proteins with two arms. So imagine a person with two arms, one that binds to the cancer cell and the other that binds to a T cell, which is a type of immune cell. So this brings the T cell in close contact with its target, forcing them to interact and triggering the T cell to kill the cancer cell. So an example of this is Blinatumomab, used for a type of acute lymphoblastic leukemia. BiTEs are like tiny matchmakers. They grab onto both a cancer cell and a T cell. They're like playing wingman and forcing them to get up close and personal. This close encounter sparks the T cell into action, and the rest they say is history. And now we'll move on to cancer vaccines, which is teaching the immune system to recognize cancer. Unlike traditional vaccines that prevent infection, cancer vaccines boost the immune system's ability to recognize and fight an existing cancer. These vaccines contain specific antigens found on cancer cells, aiming to train the immune system to target cells carrying those markers. The typed cancer vaccines can be cell-based, using the patient's own tumor cells or immune cells to create the vaccine, or protein-based, using specific proteins or small fragments of proteins, peptides found on cancer cells. Cancer vaccines are like showing a wanted poster of cancer-specific markers to your immune system, priming it to be on the lookout and launch an attack if those markers are ever spotted. So an important note on immunotherapy. They have evolving uses. Immunotherapy has proven highly effective in certain cancers like melanoma, some lung cancers, and some lymphomas. Research is ongoing to expand its use to more cancer types and to combine it with other therapies as well. They have unique side effects. Immune checkpoint inhibitors, while often better tolerated than traditional chemotherapy, can lead to side effects where an overactive immune system starts attacking healthy tissues. Careful management of these side effects is crucial. And also to highlight again the importance of biomarkers. Not everyone responds to immunotherapy. Identifying biomarkers that predict who will benefit is a major focus of research. And now a quick talk on the future of immunotherapy. So this field holds tremendous promise. Harnessing the intricate power of the immune system opens exciting new avenues in cancer treatment with the potential for long-term remission and even cures. Wow, right. So we covered a lot of ground over the past two, from understanding what systemic treatments are to diving into cytotoxic chemotherapy, targeted therapies, and the amazing world of immunotherapy. Don't worry, we'll venture into each of these in more detail later on in the series when we tackle specific cancers and specific treatments. I hope you now feel a small bit more equipped to understand systemic anti-cancer treatments. If you're someone starting off in the world of cancer care, remember these are powerful medications and each one has its own uniqueness and considerations. Thanks again for joining us on the Irish Hematology Oncology podcast today. I know I flew through loads of stuff, and as I said, we'll be going into more detail later on, but I hope you found this episode and last week's episode helpful. Please subscribe and leave a review and tell your colleagues about this podcast. Your support helps us continue bringing valuable information on these treatments and all cancer care in general. To those of you who've already filled out the feedback form, thanks a million. And a reminder to all, fill out the feedback form to give me an idea if this has been helpful, how we can improve, and any future episodes or topics you'd like to hear. And don't forget to log that important CPD, an example of which can be found in the show notes below. And as always, I end with this important disclaimer. This podcast is for educational purposes only. Remember, the field of cancer care is always advancing, and new research may lead to changes in treatment approaches or protocols. Always consult with your own team for personalized guidance and discuss any information from this podcast with them. Seek information from trusted local and national resources for the most up-to-date recommendations. All right, thanks. Catch you next week.